ear reconstruction, it's often perceived it's microtia, because everybody loves to talk about microtia. But there is a big part in ear reconstruction which is for traumatic ear reconstruction. And in my practice, that's a very, very big part. And I think that's one part where METPOR probably plays less of a role when you have the partial defects. Ear reconstruction can be congenital, like microtia, or it can be acquired, such as a traumatic amputation of the ear. Where I work at the Royal Free Hospital, microtia reconstruction is probably the biggest part of our work, but a significant part, nearly 40%, will be traumatic amputation. We also deal with burns, complications of other surgery, and infection. So the traumatic amputation in England, the majority are human bites. Now, people laugh at this. I don't know. In England, it's alcohol related. No doubt, people go out, they get drunk, and I don't know why, but some people even assault other people for no reason and bite their ears. And, sorry, it's moving away. What's interesting is when I do this talk in Europe, the Europeans are very surprised. So it's probably more of a British thing than a European thing. But then I speak to Iraqis, they have that problem too. So I don't know. I think it's a very specific problem to specific countries. But in England, it is common. And they present very differently. Each one has a very different presentation. There are subtotal amputation, and they're very interesting to manage. The psychological problem is massive, absolutely massive for these patients. Their life is put on hold. They won't leave the house. Their personality, their relationships, everything changes when you have, especially for the men, which are the majority. And as I said, a lot of it is beer and alcohol related. So a typical human bite injury will involve partial loss of the upper third, the middle third, or the lower third. And they do require a lot of planning. I mean, yes, it is planning-wise potentially more complicated than microtia, but then you are dealing with less rib requirement, and the adult rib is much thicker, and you can often carve what you need from one thick rib. The road traffic accidents are less common, but I do see them. Often the skin, there's scarring, there's tattooing, and they do make the surgery very, very difficult to plan. But the most difficult are the burns. Each one is unique, and it depends what skin has been spared, what can be offered. And lastly, we get one more. We get another group who've had skin cancer, who have had melanoma removed or basal cell carcinoma. They're not very common because the majority of these patients in England are elderly and they don't seek reconstruction. But they do present to my service, and there's infection as well. So the principles that you should follow in a traumatic, only consider reconstruction when the injury has fully healed. So don't consider reconstruction in the acute phase of surgery, of injury. Always the limiting factor will be the skin availability and the scarring, and use the temporal parietal flap when the skin is insufficient. The important factors take into consideration the age of the patient at presentation, smoking, which is a big part in adult life and plays a big part in skin vascularity, and the psychology. So the reconstruction in trauma, it all depends what is required, because if there is a small helical rim defect, you can take that from one rib only. If there is a larger defect, you'll require more rib. So the amount of rib that you harvest will depend on the defect. The skin coverage is almost always trying to use the available mastoid skin. You're raising a posteriorly based flap, and you're attaching the lower and the upper part of the ear to the head to allow the flap to advance over the rib cartilage. And you carve your framework as needed, and you cover it with the flap. And you can see here, this is a subtotal amputation with a rib framework inserted for this defect. Another approach, which I don't use very often, is if you're worried about the blood supply, you can do a bipedical type flap, maintaining attachment to the original scar. It is harder to dissect, but it is a safer technique. I don't really use it very often, but my predecessor, David Galt, used it all the time. But I've found I'm quite comfortable just raising just a posteriorly based flap. And this is how I plan it. It's really important to get a wide base in the flap. So the dotted line is the base of the flap, and the other lines will be the incisions for the reconstruction. And you can see here when the flap is raised, you can cover the framework with it. It's very important to take into consideration the tension, the vascularity, and the judgment. There's a lot of judgment to be done. I mean, I've done hundreds and hundreds of traumatic cases, and even now, I still have difficulty making the right plan. When I started for a helical rim defect, I used to use a floating rib, and I used to use a strut of cartilage to hold them together. It does give a very nice helical rim, but often there's a problem, as you can see, where they attach, because it has a tendency to want to move outwards. So then I've moved towards carving a whole 3D component from one piece of rib, because adult rib is thick enough, and when you insert that, then the curvature is natural and normal, and you get a really nice result with rib. So when I see this patients, and I see my colleagues in England too, shall we use conchal cartilage? Shall we use a pedicled flap? Shall we use this? I said, no. Look, you can get such a beautiful result with rib, and it's not a big operation for the patient. It is a difficult operation, but it's not right for the patient, not to have this option available to them. So I definitely don't advocate using conchal cartilage for a very small defect, but using all these pedicled skin flaps, you will get nowhere as good a result as you will with rib. But it takes time to accept that this operation is not a major operation. It takes a lot of experience. So when you have loss of the rim of the antihelix, you create a partial construct of the helical rim and the antihelix, and you cover that with the appropriate flap. Again, the same thing here, but here I've used one block. I've carved the whole thing just from one block, which you can do with adults. Total ear loss, as in accidents, these are pretty similar to MICROTIA, and you'll be carving a total framework and trying to create as best vascularized skin pocket as possible. I have used tissue expansion on some of these cases when I started, but the difficulty with tissue expansion is the capsule that you have to remove, because you can't have the capsule over the framework. So it is a lot of work. It's time consuming in the clinic. It's definitely not my preferred choice now, because the skin becomes quite thin, but I have had success, so I'm not totally against tissue expansion, like some of my ear reconstruction colleagues are, but I'm not. What I do like is a technique described by Francois Fermont. It's what's called indirect tissue expansion, where if you feel the skin's a little bit tight, you can place an expander under the scalp, and that takes away the tension, but then you don't have to remove the capsule, because you can insert the framework in the place when you take the expander. Again, there's a lot of outpatient work, expanding, following the patient. Possibly now I would elect to use a temporoparietal fascia, but I think tissue expansion is a very good option. In these very scarred cases, you have no option but to use temporoparietal fascia. This patient had the temporal artery damaged, so I actually used a random-based wide temporoparietal fascia, which I covered the block. So there's always ways to create a fascial flap. When the earlobe is damaged, again, there is no option but rib. I know our earlobes don't have cartilage, but unfortunately it's not possible with skin to create an earlobe, because the skin will shrink. So you need structure. If you want to create an earlobe, you need some sort of structure, whether it's rib cartilage or conchal cartilage. This is all with rib. This is a melanoma. The previous one was human bite, rib cartilage, and it does give a lovely result. It is a little bit of extra work, and you can use conchal cartilage for very small defects. But actually the conchal cartilage, in a way, it's more difficult, because then you have to design skin flaps. So you have a little bit of conchal cartilage, you have an anterior skin flap designed to do a scar, or you sometimes have an anterior skin flap and a sliding posterior skin flap. And all it takes is a small infection and you can have a problem. But these results can give quite a nice earlobes. Obviously they are limited in the sense they cannot reconstruct the helical rim. Infection cases are common in England because the young ladies, they love piercing their upper cartilage, which I'm totally against. I don't know why people like piercing the cartilage, but if you get an infection, if it's not treated, the cartilage loss is very quick with infection. But these cases can all be managed with rib cartilage. So here I decided to remove the whole antihelical abnormality and the helical rim and insert a rib cartilage framework. Again, another young boy who lost his ear because of infection, and this is a rib cartilage, total rib cartilage framework inserted, and 2-stage. You can sometimes do it in 1 stage. There is a skin pocket, but depending on how much is required. When you have cases like this from road traffic accidents, you can again select to insert a small amount of rib. Needs a lot of planning to get that incorporated into the framework. Again, another example where the whole helical rim just carved from 1 piece of rib, because we have the ability to do that in adult ribs, but not in children ribs. As I said, burns is very difficult cases, but often you'll find the mastoid skin is spared in burns, and so I try to use that. So I remove the burnt cartilage and insert a piece of rib under the mastoid skin. And you can get some very nice results with that, but there are greater risks with the burns patients, but often it's possible to reconstruct these cases. But severe burns, like this particular case, here I actually expanded the burnt skin, and I was able to insert a framework under the skin graft. Probably not something I would do now, but when I was starting out, I tried many things with ear reconstruction, many things. The second stage in the traumatic cases is a little bit easier than MICROTIA. The reason being is that when you release a partial ear reconstruction, it tends to spring out. The conchal ball is intact, and you can have excellent projection with a skin graft for partial reconstruction. But when you have a total ear reconstruction, you have to use the MICROTIA technique that we use, I described earlier, like a TP flap or a skin graft, depending on what your aim is. Just a small point, again, not every ear reconstruction surgeon likes this, but I found when I have the earlobe to release, the earlobe doesn't have enough tissue to get a good skin graft, because it's sitting right where the parotid fascia is, and I found incorporating a small flap of skin just gives me more safety to cover the earlobe. It does compromise and give a scar in the neck, but I get better cover behind the earlobe. Again, this is a small child who lost her earlobe, and I put a small piece of rib in there, and then I released it with a little flap at the back, and you can see get a lovely result. These cases can be very difficult to manage psychologically in the public service because there's a waiting list. And sometimes my waiting list is 1.5 years, 2 years, and having this patient in the clinic whose life is on hold is not easy. It's not easy, actually, and there's nothing you can do. You tell them this operation takes 6 hours. I can't offer it to you in the next month. And privately, these operations are very expensive. In England, if you're spending 8 hours in theatre, already the hospital will take 10,000, 20,000 pounds. So and these patients don't have the money. So it is a very difficult situation to manage sort of privately. And thank you very much. That's it.
Thank you, Dr. شكرا دكتور وليد for this presentation. دكتور أحمد